Okay, guys, I apologize. I'm going to re-record this because I just listened to the upload I did last night and the audio is absolute trash. So I'm going to start again. So today we are going through the induction phase of a general anesthetic. So previously we've gone through the preoperative phase of the clinical portion, we've gone through the procedural sedation, and now is when we're going to be starting those four phases of a general anesthetic. So we have induction, maintenance, emergence, and recovery. So today the entire focus will be on the induction phase itself. The goals or the objectives of today's lesson are I want to go through the reasons or the contraindications why we would utilize an endotracheal tube versus utilizing a supraglottic airway in a general anesthetic. Then I want to go through the physiological effects of intubation and the different mitigation strategies for those issues. Then we're going to go through the steps of a typical induction of a general anesthetic. This isn't going to vary too much in the way of your induction you've done in your ICU induction, emergency, etc. And then we're also going to compare it and contrast it to an RSI and how that differs from our standard induction. We'll also briefly go through awake intubations. Then we're going to go through the different factors that affect the IV anesthetic uptake, and we'll compare those different IV anesthetics. So our propofol, etomidate, and ketamine. We will not be covering methotrexate. We will also go through the key features of the main opioid that we utilize in the operating room, which is fentanyl, and then we will end with going through succinylcholine versus rocuronium, so our different neuromuscular blocking agents. General anesthesia is the utilization of drugs to produce both a state of reversible loss of consciousness as well as a state of lost and diminished sensation. So, this is how that varies from our procedural sedation we spoke about last week. An easy way or an acronym to understand what encompasses a general anesthetic is SAM. So, S is for sedation, which brings us our unconsciousness. A is for analgesia, and M is for muscle relaxation. With a general anesthetic, we require these three components. Muscle relaxation is one of those things, it can depend on the surgery and the patient and the surgeon's preferences, but the main two focuses are always going to be an element of sedation and an element of analgesia, most likely utilizing muscle relaxation as well. When it comes to induction as a timeline, the induction of a general anesthetic is that phase where we're going from awake to unconsciousness. So this slide is a little bit confusing because we're talking about starts once the surgical safety checklist is done and begins with giving the patient the first drug. I'm going to go ahead and take out this first line here. So induction is going to begin when we give the person or the patient the very first drug in the operating room. So not a preoperative drug in the waiting area or in the day surgery area. It's once they get that first medication that is starting the induction phase. We are going to be intubating imminently. This is when the induction phase begins. It ends when surgical anesthesia is established. So once the surgeon is happy with the way that the anesthetist has the anesthetist is done their induction phase, the patient is on the ventilator, they're happy, they're on their monitoring phase, we can begin maintenance. That is when induction is done. So there are three main forms of induction that we're going to speak about today. The first is a typical IV induction. So this is the most common method of induction because we get that rapid onset of unconsciousness. It's more predictable. We're able to give a patient a measured amount of anesthetic, and with the knowledge of the drug capacity, we will have a better idea of like what's going to happen to the patient. It's more controlled. RSI is something that we give to a patient who is when we are needing that fast induction technique because aspiration risk is high. You guys have been through this before in other classes, but we need that rapid administration of an induction agent and paralytic, and we give them absolutely no ventilation before intubation to quickly secure that airway and diminish the risk of aspiration. Now, awake intubation is when we are securing an airway while the patient remains awake but sedated and they're breathing spontaneously. This is used usually when a difficult airway is anticipated because we want to have much more control and be able to keep a patient awake and breathing so that we are not losing an airway. This is normally those patients that are absolutely horrendous or difficult to bag, and we're worried about what type of airway they're actually going to have. So these could be patients that are coming in, they have their note from their previous surgeon saying, I have a very anterior airway. They may need to have some type of awake intubation done to ensure that this patient does not get paralyzed, um, and we are unable to bag them, because that is absolutely the worst case scenario. So typical IV induction is the one we're going to mainly focus on in this class. As RTs, this is what you'll see most likely in the ICU, in emergency, and when you go through your week in the operating room. And the one thing I'd like you guys to know with a typical IV induction is it uses a combination of drugs that each serve a specific purpose, and we will go through those drugs today. That being said, it is something we call a balanced induction, and this is because every anesthetist is different. Every combination and drugs used is going to be completely different depending on the site you go to, depending on which anesthetist you're working with, and which patient they are working with. So it's kind of an art versus a science. Some anesthetists use a very minimal concept. They will use just the drugs they need, the baseline drugs, for example, propofol, a fentanyl, and then a paralytic, and that's it. Other anesthetists are going to utilize a lot more combination of drugs, so they might utilize some remifentanil, they might utilize more midazolam, ketamine, etc. None of them are wrong. Everybody just has their own methods. And then we're also going to talk about the reasons why we might use an LMA or an endotracheal tube, and which one needs the paralysis. When it comes to what type of airway that we are deciding on in the operating room, there's a couple different elements you guys are maybe familiar with for other classes, but in the operating room, it's very important to be able to distinguish what is appropriate for an endotracheal tube and when it is appropriate to use a supraglottic. So an endotracheal tube is obviously going to be much more secure. It's better at preventing aspiration because of that distal cuff we have below the vocal cords. We're also going to utilize it for RSI cases. Those patients that were worried about aspiration risk, it's absolutely imperative that we're using an endotracheal tube. Patients that are requiring a laparoscopic surgery. So during a laparoscopic surgery, the surgeon has different tools that are injecting CO2 gas inside of the abdominal cavity to allow for better visualization. So we need something in place that's going to handle higher airway pressures for ventilation. We also get an increased intra-abdominal pressure from that different positioning and the tools. So an endotracheal tube is going to have better control of CO2 elimination during that insufflation. If we have a supraglottic airway in place instead of an endotracheal tube, it's not going to be good enough with the pressures that are going to be placed on the diaphragm from that laparoscopic surgery CO2 placement. Also, patients that have a higher BMI, it's often much safer to have an endotracheal tube in place versus just an LMA. This is because of airway anatomy, because of the extra abdominal pressure, just like with a laparoscopic surgery. Also, any type of surgery that you're going anywhere other than supine. So if you envision a patient on side lying or a patient going prone, even if an LMA was taped down in place, it is very finicky. They're very hard to position and not get a leak. That being said, an endotracheal tube absolutely needs to be placed if you were going anything other than supine. And then last but absolutely not least, if you require paralysis, you absolutely must place an endotracheal tube. You cannot use an LMA for a paralyzed patient. So with a supraglottic airway, we can use it for the patients that do not require paralysis. A pro to a supraglottic airway is obviously because we're not going through the cords, there is no risk to vocal cord damage. Therefore, they are often simpler and they can be easier for beginners to place depending on the type of LMA that they are. That being said, they are extremely finicky. Sometimes certain LMAs do not sit properly in certain people's airways versus an endotracheal tube you know is going to sit flush. You're going to be able to get the cuff up and ventilate a patient once it's through the cords. LMAs do not always sit perfectly in different people's airways. So it's going to be difficult to position them depending on the one you're using. So if you envision a king tube versus an eye gel, they're going to sit completely different in patients. And then last but not least, with supraglottic airways, they're not appropriate for long-term ventilation. So in terms of testing, I'm going to say anything over 4 hours is absolutely not appropriate to have an LMA in place. So anything under 4 hours without a paralytic, etc., can get away with having an LMA. Anything above absolutely needs to have an endotracheal tube in place. So I want to clarify something that can be a little bit confusing. In anesthesia, we use the word induction in two different ways. So first we have the phases of anesthesia care, which is going to describe that timeline of anesthesia that we've talked about to this date. So we have induction, we have maintenance, emergence, and recovery. But within that induction phase itself, our patients are going to pass through different stages of anesthetic depth, and these are called the stages of anesthesia or Guidel's stages of anesthesia. So, stage one is induction, stage two is delirium or excitement, stage three is surgical, and stage four is overdose. So today when we talk about induction, or during the next couple slides, we're going to be focusing on the stages of anesthesia that occur as a patient is going to transition from awake to surgical. Stage one begins with anesthetic administration, and it's going to continue until the patient loses consciousness. During this phase, patients experience drowsiness, significant pain relief while maintaining normal breathing patterns and protective reflexes. Common induction agents that are going to be utilized during this stage include propofol, etomidate, sevoflurane. Those specific choices are going to depend obviously on patient factors and surgical requirements. The duration of stage one is going to vary based on the anesthetic technique and individual patient response. Anesthetists are going to have to carefully control this phase because overly rapid induction can compromise the airway, while prolonged induction can increase the patient's discomfort and anxiety. So, from the patient's perspective, this stage is often remembered as being calm or even euphoric, which can be reassuring if we're explaining it beforehand. The stage proves particularly useful for minor procedures, so things like dental work, or as a preparation for deeper anesthetic levels that are required for major surgery. So, in this phase, a patient is normal, has a normal breathing pattern, they have stable vital signs. This is the phase right before they're going unconscious. During stage two, or excitation delirium, the brain is in an unstable state and reflexes are exaggerated. This is when the patient is in the midst of falling asleep. So here, your airway reflexes like coughing or laryngospasm can be triggered extremely easily. We try to avoid stimulating or touching the patient at all during this phase, and we want them to move quickly through this stage if they do reach it. Stage two represents that transition period where patients are going to be losing consciousness, but they're experiencing irregular physiological responses. This stage requires careful management due to the increased risk of complications and unpredictable patient reactions. So some significant risks during this stage include vomiting, irregular heartbeat, respiratory complications. Anesthetists and AAs want to work to minimize the time spent in stage two. They want to do this by using rapid acting agents and smooth induction techniques. Airway management obviously also becomes a key priority here, as a laryngospasm and irregular breathing patterns pose a real risk. Historically, with older drugs like ether, this stage was much more prolonged, but with modern drugs and muscle relaxants now, we can actually keep this time frame extremely short or almost bypass it altogether. Premedication and careful drug selection are going to help the patient transition quickly through this potentially dangerous phase towards that stability phase of surgical anesthesia, which is next. Stage three, or surgical, the surgical phase, provides optimal conditions for surgical procedures, with patients maintaining unconsciousness, stable breathing, and appropriate muscle relaxation. This stage is actually further divided into 4 planes, which range from light to deep surgical anesthesia, but for the purpose of this class, we will not be going into those. I only care about you guys knowing these 4 phases of Guidel's stages of depth. So either induction, delirium, surgical, and overdose. We don't need to go into the depths of surgical anesthetic itself. The role of the anesthetist during this phase is going to be continuous monitoring to make sure that the patient's remaining at an appropriate depth for surgery while avoiding progression towards stage 4, which is overdose. Modern anesthetic techniques are going to allow precise control within this stage using multiple monitoring parameters. Different surgical procedures are going to require varying depths within stage 3. So, with more invasive operations, obviously, we're going to be needing deeper and more optimal surgical conditions and patient comfort. But that being said, for testing purposes, surgical is ideally when our intubation is going to occur, and this is when our surgery actually takes place. If anesthesia becomes too deep and the patient enters stage 4, there can be severe respiratory and cardiovascular depression. Management focuses on supporting the airway, ventilating with oxygen, reducing anesthetic agents, and supporting blood pressure and circulation. So, stage 4 represents a dangerous level of anesthetic overdose that is never a goal of modern anesthesia practice. The name here, overdose or medullary depression, actually comes from the suppression of the medulla oblongata in the brainstem. So, this is the region that controls all our essential functions. So, our breathing, our heart rate, our blood pressure. When anesthetic depth reaches this stage, these vital centers slow down or they actually stop functioning, which leads to respiratory failure and cardiovascular collapse if it's not corrected immediately. Careful monitoring and precise drug administration prevents our patients from reaching this stage of stage 4. Modern anesthetic practices include multiple safety systems, continuous vital sign monitoring, and immediate intervention protocols to maintain patient safety. So, the reason this stage is taught is so anesthetists and AAs, etc., can recognize early warning signs and intervene immediately, even though it's not intended as part of modern practice. In the early stage of anesthesia, obviously, stage 4 occurred a lot more often, but with today's agents and monitoring, progression to this stage is extremely rare. So, the signs of a patient headed towards this phase are respiratory failure due to depression of the breathing centers. Obviously, our patients are going to be on ventilators at this point. But if we were to wean or we were to reverse these patients to a conscious state, they would not be able to breathe on their own. Their pupils will also go to a fixed and dilated form. They will have absolutely no reflexes present, and they will have complete muscle flaccidity. They will also experience a cardiovascular collapse, so we're going to see a severe drop in their blood pressure, which can then lead to a potential cardiac arrest if not immediately corrected. So for these stages, we also utilize something called a BIS or an entropy monitor, which we'll talk about on Thursday when we go through maintenance. But what this is it's essentially an ongoing EEG monitor during a procedure. So a lot of anesthetists use these nowadays for every surgery because this kind of tells us almost how deep a patient is asleep. There's safe levels that we talk about, and it's once a patient goes too high or too low, I should say, they're almost at the risk of being overdosed with medication. So we want to keep them in the safe parameters. You guys have seen this probably a million times by now, but we're going to quickly go through the potential physiological effects of induction. So, what can happen when we're inducing a patient, we're placing a tube, etc. So, when we perform laryngoscopy and intubation, our body is going to respond to the stimulation of the airway. First, we see that CNS stimulation, which can increase cerebral blood flow, our ICP, our cerebral metabolic rate. And this is the rate at which the brain consumes our energy resources, primarily oxygen or our CMRO2, and our glucose to maintain cellular integrity and neuronal function. So, this is going to be particularly important to consider in any of our patients that are coming in with head injuries or already have an elevated ICP, or any of the patients that we are not wanting to risk having an elevated ICP or an elevated IOP. Second, there is autonomic nervous system stimulation. So in adults, this is usually going to produce a sympathetic response, resulting in tachycardia and hypertension, which can obviously increase our myocardial oxygen demand, and therefore potentially precipitate ischemia in high-risk patients. In pediatrics patients, however, we know that our airway stimulation can often trigger a parasympathetic response, which leads to a bradycardia. After that initial stimulation, though, our blood pressure may begin to drop, especially once our PPV begins because our preload is decreasing. Finally, we can see our respiratory responses. So we have coughing, laryngospasm, or bronchospasm. These reactions increase airway resistance, obviously, and then we know as RTs that this can make ventilation a lot more difficult. Before induction of a general anesthetic, so we're back to just going through induction, we're going to be intubating in the next couple minutes. We may often give some pre-treatment medication to reduce some of the physiologic responses that are going to be associated with airway manipulation and anesthetic drugs. So an acronym that we utilize for this is LOAD, LOAD. So L is for lidocaine, and lidocaine can be given prior to intubation to help suppress the cough reflex. This is going to be particularly useful again in patients where coughing could be harmful. So those patients who have an elevated ICP, because coughing can significantly obviously increase our ICP. O is for opioids such as fentanyl. Fentanyl is often used to blunt the sympathetic response that occurs during laryngoscopy and intubation. Airway manipulation can cause significant increase in our heart rate and our blood pressure, so opioids are going to help reduce that stress response. In pediatric patients, A is atropine, and it may be given to prevent that vagal-mediated bradycardia. Children are a lot more prone to developing bradycardia during our airway stimulation or with certain anesthetic medications. And then finally, D is going to be for a defasciculating agent, which can be given before giving succinylcholine. This involves giving usually a small dose, about 10% of the ED95, of a non-depolarizing neuromuscular blocker. And this is going to help reduce the muscle fasciculations that succinylcholine can cause, which can otherwise lead to complications. So we can get an increased ICP, again, increased IOP, and post-op muscle pain. These aren't utilized extremely common, any of these medications like LO, A, and D, but they're extremely knowledgeable to have in case you have patients that could require them. So the patient's inside of the operating room, and now we can start to give them the pre-medication to the induction drug. And when I'm talking about the induction drug, I'm talking about the drug that is going to put the patient to sleep. So propofol, etomidate, etc. So some pre-medication examples that we can give are going to help prepare the patient physiologically but also psychologically for airway management. So for pre-medication, one commonly used drug is midazolam, which is obviously a benzodiazepine. And midazolam is going to help reduce patient anxiety and also produce a bit of an anterograde amnesia, meaning that the patient is unlikely to remember the events surrounding induction, which is a goal. Another common medication is fentanyl, an opioid. Fentanyl is often given to blunt the sympathetic response that occurs with laryngoscopy and intubation. Without this, our airway stimulation can lead to increases in heart rate and blood pressure, which can be harmful to certain patients. The next important step is pre-oxygenation. I know you guys know all about this by now. So this is obviously going to deliver high concentrations of oxygen, typically through a simple mask or through the mask on the anesthetic machine. We just want the goal, obviously, to completely give the replace all the nitrogen in the lungs with oxygen, create that oxygen reservoir for the FRC. By doing this, we're going to extend that safe apnea time. So we want to make sure that we're pre-oxygenating our patient for as long as we are capable and we have time for, especially in the case of an RSI. So just like all the inductions you have experienced in the past or previous classes, an example of very common induction steps is going to be 1, pre-oxygenate your patient. 2, give a patient some type of benzodiazepine to ease their anxiety and minimize memory. So in this case, midazolam. Then we want to give our opioid to blunt the sympathetic surge from intubation. So fentanyl. And then we want to give our induction agent, which is going to be propofol to cause unconsciousness. Lastly, after the patient is completely unconscious is when we would give them their neuromuscular blocker to paralyze the vocal cords and prepare them for intubation. Now this, with a normal IV induction, after the patient is paralyzed, is when we would begin to bag them prior to intubation. When administering medications during anesthesia, our drug timing is obviously going to be very important. Several factors influence when and how medications should be given to achieve the desired clinical effect. So first, we want to consider whether the medication should be given as a bolus or as an infusion. A bolus dose is going to produce a rapid effect, which is what we want during an induction, while infusions are typically going to be used to maintain a steady drug level over time. So an infusion or a TIVA is normally going to be utilized during a maintenance phase, while a bolus is what we require for the actual phase of induction. Next, we need to understand the pharmacology of each drug. Different medications are going to have different mechanisms of action and physiological effects, which influence how and when they should be administered. And we also need to consider the onset of action, which is going to be how quickly that drug begins to take effect after administration. And then closely related to that is the peak effect, which is the point at which the drug produces its maximum clinical effect. Timing the airway manipulation, for example, often depends on reaching this peak effect. Another important factor is the duration of action, which tells us how long the medication is going to continue to work. So, for example, succinylcholine is going to wear off a lot quicker than rocuronium. So this is going to help us guide our decision about redosing or when to transition to maintenance anesthesia. And circulation time is also going to play a role. Drugs that are given IV must travel through the circulation before reaching their target organ. So a patient's cardiac output and overall cardiovascular function can influence how quickly a drug is going to take effect. And then finally, we consider drug metabolism and clearance, particularly hepatic and renal function. So if we have a patient who has impaired liver or kidney function, drugs are going to last longer or they're going to start to accumulate, which can significantly affect our dosing decisions. Okay, so I took these tables from Dave. They're talking about one, induction timing of a normal IV induction, and then the second one we'll talk about is an RSI timing induction. What I'd like you guys to take from this is the order of events. I wouldn't worry too much about the timing here, and I don't want you guys to worry about the dosaging. We will go through dosaging at a later date or later on in this PowerPoint, but I don't want you guys to look at the dosaging in this example and memorize it in any capacity. So first, before the patient even enters the room, this is something that we spoke about last week in the preoperative stage. So we go through our MISMAID, so our machine check, our suctions, our monitors. We want our airway plan A, B, and C. We want to have all our IV supplies out and all of our drugs ready. Prior to the endotracheal tube going into the patient, we obviously need to pre-oxygenate. Then this is when we start to give our pre-medications, so our small dose of fentanyl or midazolam, and then we're going to start to give our propofol. After this, when the patient is asleep and unconscious, is when we start to bag the patient and give that induction dose of rocuronium. After the patient is paralyzed, this is when we do perform laryngoscopy and our tube is placed and the cuff is inflated, correct placement is confirmed. After that is when the patient is put onto the mechanical ventilator. So this is absolutely nothing new for what you guys have seen in the past or in your other classes. What I want you guys to take away from this is just the order of events. So first we have our pre-oxygenation. Then we have fentanyl and midazolam. So we have an opioid and a benzodiazepine. After that is when we give our induction agent, so our propofol or our etomidate or our ketamine. The top-up dose of fentanyl is very site-dependent, very anesthetist-dependent. I wouldn't worry about that in terms of timeline. After this, when the patient has gone unconscious, is when we start to bag. Obviously, we don't want to be bagging a patient who is not yet unconscious, so bagging comes next. After the patient is unconscious is when we give the succinylcholine or rocuronium. This is very important. We don't want to be paralyzing a patient who is not yet unconscious. After that is when the laryngoscopy is performed, tube is placed, cuff is up, placed on the ventilator. You guys are very familiar with this. So please don't worry about timelines here, like our minutes, and do not worry about dosaging. And then next we're going to talk about RSI. You guys have seen RSI in previous classes, but a rapid sequence induction is going to be intubation during induction without manual ventilation beforehand. So the purpose and why we do this is to minimize the risk of aspiration in patients that are prone to regurgitation and vomiting. So some indications of RSI are full stomach, obesity. We're going to go with BMI over 40. Just to coincide with what we spoke about last week. Patients with GERD, bowel obstruction, pregnancy because of the full stomach capacity, and any type of patients that are emergent or trauma because we don't know their NPO status. Obviously, these are going to differ from a typical IV induction because we can utilize cricoid pressure. We do not utilize manual ventilation and predetermined drug dosages. We're not going to go through that. Cross that one out. 7 P's of an RSI. These are important I wouldn't fixate too much on them because they do come into play and they end up being more common sense. But we always want to have preparation, pre-oxygenation, pre-intubation optimization, paralysis with induction, positioning, placement with proof, and post-intubation management. So we're going to go through a timeline next of an RSI. Just talking more about RSI intubation here, we usually are going to utilize propofol or ketamine. We're going to be using cricoid pressure, just like we spoke about last week, not burp. We're going to use a paralytic in these cases for sure. So we're going to be using rocuronium or succinylcholine. And we want something that is short acting for intubation. We want to have fast acting drugs so that we can intubate quickly without having to bag the patient. Usually for RSIs, we're going to be going for a propofol because of its quick onset. We're going to be giving a fentanyl. We're also going to be using succinylcholine just because of its quicker onset and offset. However, rocuronium can be utilized for these patients. I think this is the third slide or PowerPoint now that we've gone through cricoid versus burp, but just to reiterate, cricoid is going to be when we're pushing down on the cricoid cartilage because with the goal to compress the esophagus. The entire reason that we do this during an RSI is to completely prevent aspiration from happening. We want to occlude the esophagus. Burp, however, is our back upright pressure, and this is what we use when we want to improve intubation view. This is not going to help an RSI case at all. So if you have an RSI, we're using cricoid pressure versus burp. And it's important with our cricoid pressure, cricoid goes on when the drugs are going in. So usually we're landmarking when the patient is still asleep. We don't have to put all the pressure on, but we want to make sure we're landmarking as the patient is still awake. Let them know that what you're doing, that you're just going to be touching their neck. And then once the patient is going to sleep, the medication's going in, that's when we put our cricoid pressure on. Cricoid does not come off until our cuff is up and our ventilation is confirmed. We want to make sure that we have end-tidal CO2 and we're able to ventilate the patient and confirm that before we even think about taking off that cricoid pressure. Okay, going through an RSI timing. Again, please do not worry about the timing on the left-hand side here. We start with our modified mismade. So this is kind of when our 7Ps come into place as well. So we're going to be preparing our airway equipment, having everything ready before we even begin this process. We also want to ensure that we're pre-oxygenating for as long as physically possible with these patients. Because we're not going to be able to bag them, we want to make sure that they are on 100% oxygen for as long as they are physically able to be. Pre-intubation optimization can be so site specific, but this is when we want to consider giving an opioid. We want to see their fluid level. Do they need more fluids before we intubate? Do they need lidocaine for cough suppressant? Do they need any pressors? What is their blood pressure like? We also will be giving either ketamine or propofol for induction agent, rocuronium or succinylcholine, but the key here is cricoid pressure. After that is when positioning is going to take place and placement and proof of endotracheal tube. So what I want you to take from your RSI here is not the specifics or this timeline. It's very site dependent. It's very patient and anesthetist dependent. I want you guys to for RSI, know that RSI is fast. It's focused on aspiration prevention with minimal ventilation, while a normal induction is slow, controlled, and allows ventilation before intubation. So with an RSI, our goal is to prevent aspiration, no bag mask ventilation before intubation. We need to use an immediate paralytic after induction agent. So right after we give our propofol or our ketamine or other induction agent, we are giving our paralytic. We want to use all the rapid acting drugs. We also want to make sure that we are using cricoid pressure with an RSI. And then for our normal or in comparison to our routine induction, the goal is a smooth, controlled induction. We always bag mask our patient, and a paralytic that we're giving can be either delayed or it can be titrated. There's also a lot more flexibility in the drug choice and timing. So that's what I want you guys to take away in terms of testing. So I'm not going to be testing you on this happens at 5 minutes, this happens at 3 minutes, this happens at 1 minute before intubation. I want you guys to be able to recognize the order of events, but also the comparison between the two. So an RSI timing and the elements of why we would use an RSI versus the induction. And I think I'll make one of those all abouts in terms of like an RSI and a normal induction for you guys. And then when we come to post-induction, obviously these are kind of common sense things, but we place a patient on a ventilator. Then this is also when we start to position the patient for surgery. So are they going to be supine, prone, Trendelenburg, reverse Trendelenburg? This is when we get to place them. The tube is secured, we have our lines in, and this is when we can go ahead and make sure that they are prepped properly for the surgery that's about to take place. And then that's when we enter our maintenance stage, which we'll speak about on Thursday. Okay, so we're going to go through the different types of medications that I would like you guys to understand for the induction phase. So propofol works as a GABA agonist. So this means it enhances the brain's main inhibitory neurotransmitter system, which is going to slow our neuronal activity and it's going to produce that sedation and unconsciousness. So what I'd like you guys to know in terms of propofol and for testing purposes, I'd like you to know it is a GABA receptor agonist. And that's all I need to know for mechanism of action. The standard dose of a propofol is going to be 10 milligrams per mil, and our induction dosage is going to be 1 to 2.5 milligrams per kilogram. So quite often we go for a healthy adult, we're going to go for 2 milligrams per kilogram. So if, for example, you have a 70 kilogram patient, we're going to give them an induction dose of 140 milligrams per kilogram. The onset of propofol, I'd like you to know, is 15 to 45 seconds, so it's quite quick, and the duration of action is 5 to 10 minutes. So as you can see, it's quite on and off, and this is why when we're running a TIVA, we have propofol running on the pump at all times at a low microgram per minute, because propofol has such a quick onset and offset. So if we have it running at all times, we can utilize it on a TIVA. Otherwise, if we use propofol as an induction agent, we need to make sure that we're putting a volatile agent on right away when the patient is intubated to make sure that there's no element of wake. So we hit them with our induction agent of propofol, it's coming off, and we've got our sevoflurane or isoflurane on. I'd like you guys to know that there is always a risk of propofol infusion syndrome. So propofol infusion syndrome is a rare, but it's a life-threatening complication of prolonged and high-dose propofol infusion. So it can cause metabolic acidosis, rhabdomyolysis, cardiac failure, and renal failure. And it's when it's most at risk is when our risk is going to increase with our high dosages. So anything over 4 milligrams per kilogram an hour and very, very long infusions. So over 48 hours. So again, propofol infusion syndrome is a very rare, but it's a serious complication that is seen with prolonged and high dose propofol infusions. I would like you guys to know that propofol is a cardiodepressant. Now, again, these are things that you guys should remember from pharmacology, but these are just the elements I'd like you to know for anesthesia, okay? And then lastly, that it is a lipid molecule profile and it can result in pain upon injection intravenously. So a lot of the times if you've had an anesthetic before, you might experience a little bit of a burning sensation going through intravenous. This is the propofol going through your line. So if you give it too quickly, it can also almost feel like a burning. That's why if we're giving propofol and we're giving it to a patient that's not requiring an RSI, we tend to push propofol a bit slower. We don't want to cause any burning in the patient's IV. Next is etomidate or amidate. Amidate or etomidate is often chosen for induction because when we want rapid hypnosis, but we need to maintain that cardiovascular stability. So a key here is the minimal effects that etomidate has on the cardiovascular system. So etomidate is a GABA receptor agonist. It's 20 milligrams per mil in its standard concentration, and the induction dose is 0.2 to 0.4 milligrams per kilogram. The onset is extremely familiar or similar to propofol at 15 to 45 seconds, and the duration of action is also quite similar at 3 to 12 minutes. In terms of why we don't use etomidate versus propofol, especially because you see that minimal effects on the cardiovascular system in comparison to propofol, which does, is that propofol is extremely popular for routine induction because it provides a smooth, rapid loss of consciousness, reliable amnesia, and even it has antiemetic benefits. And obviously, the downside is going to be it can cause significant hypotension and respiratory depression. So, with etomidate, however, it maintains our blood pressure and our cardiac output much better than propofol. However, the advantage is going to come at a cost here. So etomidate suppresses adrenal steroid synthesis even after a single dose. So this can reduce a patient's cortisol production for hours, and it can also impair the patient's stress response in critically ill patients. So etomidate can also cause myoclonic movements or even more pain on injection, and it lacks that antiemetic property of propofol. Because of this, etomidate is generally reserved for very, very specific scenarios where hemodynamic stability is essential. So, patients that might need etomidate versus those that need propofol are going to be cases like a trauma, a septic patient, or a very severe cardiac compromise. For the average patient, though, propofol is preferred because it has more favorable side effect profile and it doesn't have any adrenal suppression. So, in summary, the choice is going to come down to patient physiology and clinical context. So, we're going to use propofol for routine induction when cardiovascular stability is not a concern, and we're going to use etomidate very, very selectively. So, again, septic patients, trauma patients, and severe cardiac compromise. And those patients who cannot tolerate any type of hypotension. But we always need to be mindful of that adrenal suppression risk. Ketamine is an induction agent that works primarily as an NMDA antagonist. So it blocks excitatory glutamate signaling in the central nervous system. And this is going to give it a unique combination of dissociative anesthesia, but also analgesia and amnesia. So it has three different elements here. So again, dissociative anesthesia, analgesia, and amnesia. So one of the best things about ketamine or its key advantages is its hemodynamic propofol. So hemodynamic profile, unlike propofol. Ketamine stimulates the sympathetic nervous system, which often increases our heart rate, our blood pressure, and our cardiac output. And this is going to make it particularly useful in those hemodynamically unstable patients or those who are at risk of hypotension and we don't want to risk decreasing their blood pressure like with propofol. Ketamine also is going to preserve our airway reflexes and our spontaneous respiration, which propofol does not. So this is going to be beneficial in certain emergency or difficult airway scenarios. However, like all the drugs, ketamine is not going to be without its drawbacks. It can cause emergence reactions like vivid dreams or hallucinations, especially in adults, and it may cause an increase in salivation. So we don't want to be using it for those oral surgeries that we can't have too much saliva. In patients with severe cardiac disease, the sympathetic stimulation can also worsen ischemia or heart failure. Additionally, it can increase intracranial and our intraocular pressure, which can limit its use in some neurologic or ophthalmologic conditions. So, ketamine is a versatile induction agent, and it's excellent for patients who need that hemodynamic support or analgesia, but we need to be aware of its psychomimetic effects and its cardiovascular effects. So ketamine, again, is an NMDA antagonist. Its standard concentration is going to be 50 milligrams per mil. An induction dose of ketamine is usually 1 to 2 milligrams per kilogram, and it has a quick onset of action in under 30 seconds. The duration is about 15 to 30 minutes, which can make it ideal for a lot of procedural sedations. And again, its effects on organ systems are essentially the opposite of propofol. It's quite hemodynamically stable. It is very prevalent in critical care since the start of the COVID-19 pandemic because of the way it maintains respirations. It can prevent a lot of those, preserve our airway reflexes, which is why we used to utilize it a lot in COVID-19 because we could get away with a lot more airway compromise. Okay, with a general anesthetic, we also obviously want to have an element of analgesia, so we want to take away the pain for the patient as well. And to do this, we utilize something called an opioid, and the main opioid that we utilize in the operating room, and the one we're going to focus on in this class, is fentanyl, which works on our mu opioid receptor. We will talk a little bit about remifentanil and sufentanil, but we won't be covering the different opioid receptors that they work on. We'll just be talking more about the potency and how they relate to fentanyl. So, fentanyl is a potent mu opioid receptor agonist, and it provides strong analgesia and some sedation. So the main reason that we utilize fentanyl is going to be because of its strong analgesic properties. It's highly lipophilic, which gives it a very rapid onset, and its duration is moderate. So it's longer than remifentanil, but it's shorter than morphine for good repeated dosaging. So what I'd like you guys to know when it comes to the potency of analgesic properties is where these drugs lay on this form. So morphine, fentanyl, remifentanil, and sufentanil. Fentanyl is going to be 80 to 100 times more potent than morphine. Remifentanil is 100 to 200 times more potent, and then sufentanil is 500 to 1,000 times more potent. I don't need you guys to memorize these values here, but I would like you to know the order that they lay in. So morphine is the least potent, then fentanyl, then remifentanil, and then sufentanil. So morphine is something that is utilized a lot in ICU, in emergency, etc. Fentanyl is one of our base drugs for induction. Remifentanil is a medication we'll talk about when we talk about maintenance more so. It's utilized quite a bit in running TIVAs. A lot of anesthetists like to incorporate a dose of remifentanil in their propofol syringe for their TIVA because it gives the patient an element of analgesia throughout the entire surgery. And because of its quick offset, we also get a very nice wake up with remifentanil. Sufentanil is extremely potent and it's often used more for pain management after a surgery. We don't often utilize sufentanil during an anesthetic. So fentanyl is an opioid agonist and it works on the mu receptor. Okay? The standard concentration of fentanyl is 50 mics per mil. The induction dose, this is extremely wrong. I don't know where this chart came from, but it's not 2 to 50. It is 1 to 3 mics per kilo. Can't write with my mouse. 1 to 3 mics per kilo. The onset of action is 2 to 3 minutes, and the duration of action is 1 to 2 hours. So some key things about fentanyl is going to give us minimal cardiovascular effects, but it is a respiratory depressant, okay? And one of the main things I'd like you guys to know about fentanyl is that it is reversed with naloxone, which is an opioid antagonist. So before we talk about neuromuscular blocking drugs, it's important to quickly review how the neuromuscular junction is going to normally work. So our neuromuscular junction is the connection between a motor neuron and a muscle cell. It is separated by a small space called the synaptic cleft. And when an action potential reaches this nerve terminal, it's going to cause calcium to enter this nerve ending. This calcium influx is going to trigger the release of acetylcholine into the synaptic cleft, and then acetylcholine is then going to bind to nicotinic acetylcholine receptors on the muscle end plate, which is going to cause depolarization of the muscle membrane and ultimately lead to muscle contraction. So these neuromuscular blocking drugs that we use in anesthesia work by interfering with this acetylcholine signaling, which is going to prevent muscle contraction, and then it's going to produce paralysis. So now looking at depolarizing neuromuscular blockers, or succinylcholine, the key idea is that they mimic acetylcholine at the receptor. So they're going to bind to the nicotinic acetylcholine receptor and cause depolarization, just like acetylcholine would. However, unlike acetylcholine, they are not rapidly broken down, and so they're going to stay bound longer. This leads to initial brief muscle excitation, which we can see as fasciculations, followed by paralysis because the receptor cannot reset itself. So since the receptor remains occupied, repolarization cannot occur, so the muscle is unable to contract again. So with succinylcholine, it's going to act as acetylcholine receptor agonist to produce rapid paralysis for intubation. So in contrast, however, non-depolarizing neuromuscular blockers like rocuronium are going to work differently. Instead of mimicking acetylcholine, they block the nicotinic acetylcholine receptor. And this means acetylcholine can't bind at all. So no depolarization occurs and the muscle never receives the signal. That's why there's no initial activation with rocuronium. We don't see any fasciculations like we do with the polarizing agents. So this results in a smooth, flaccid paralysis. So this is going to be ideal for patients that we don't want to be causing any type of fasciculations. We don't want any increase in ICP or IOP, etc. So rocuronium is our example of this drug. So for our non-depolarizing, drug, neuromuscular blocker, we're going to be talking about obviously rocuronium. And rocuronium is a non-depolarizing neuromuscular blocker. The standard concentration is 10 milligrams per mil. Induction dose is 0.6 to 1.2 milligrams per kilogram. Its onset of action is quite similar to Sux with 45 to 90 seconds, and its duration is much, much longer. So it's going to be 35 to 75 minutes long. So it takes a very long time. However, the good news, it is reversed with Sugamidex. Some things we should be aware about, however, with rocuronium is there is a higher risk of anaphylaxis. It can cause tachycardia, and we don't want to be giving it to patients that have myasthenia gravis. So in myasthenia gravis, there are fewer acetylcholine receptors available. So when we give a non-depolarizing blocker like rocuronium, it can cause an exaggerated and extremely prolonged paralysis. And last but not least is succinylcholine. So succinylcholine is our example of our depolarizing neuromuscular blocker. The standard concentration is 20 milligrams per mil. The induction dose is 1 to 2 milligrams per kilogram, so it's very similar to the induction dose of propofol. Onset of action is 30 seconds, and the duration is much, much shorter than rocuronium at 5 to 10 minutes, which is a good thing because it has absolutely no reversal agent. Some things I'd like you guys to be aware of succinylcholine is that it can cause hyperkalemia. It can cause myoglobinuria, which is the presence of myoglobin in the urine, and this is caused when our muscles break down. So when we have a case of rhabdomyolysis, and this happens with succinylcholine because it can cause muscle depolarization and those fasciculations, which can worsen our muscle breakdown, which leads to an increase in myoglobin release. So this is going to lead to a higher risk of kidney injury and dangerous hyperkalemia. I'd also like you guys to focus on the fact that succinylcholine is the trigger for MH. So we have our volatile anesthetics we know now and our succinylcholine. These are the triggers for malignant hyperthermia, which is why if a patient ever comes in, they have a family history or a personal history of an MH, we would always be reaching for rocuronium versus a succinylcholine. Okay, so I apologize for having to re-upload this presentation. I hope it worked better than the first time that I uploaded it. Please send me an email if you have any questions, and if not, I will see you guys on Thursday.